Thanks for coming to another York Union event. Today we'll be introducing Elizabeth Pisani. Elizabeth has had a glittering career, one which I hope I can emulate in some way. She's worked in the Far East, she's worked in places like the World Health Organization. She's changed her career track from journalism, actually covering the Tiananmen Square protest in '89 with Reuters. She's worked with the Asia Times, The Economist, and more recently she's moved her work to epidemiology, working for the Teranyata Health Organization, concerned with health policy and ensuring the country is more well informed about HIV and AIDS and making the right decisions. In the not long ago actually, she wrote a controversial book called The Wisdom of Cause. In it she details her life's work in the Far East, working with HIV sufferers, people with AIDS, and she tried to show how the government can, in a few simple steps, move to combat the problems. Especially with her TED talk as well, she showed how humans actually make rational decisions. It's actually the governments who fail to reconcile and make the appropriate policy decisions to help people stop spreading HIV. I'll stop talking. Our hashtag today is HIV York, so please get so I introduce to you author, journalist, epidemiologist, and the biggest antibody to HIV in existence, Elizabeth Pisani.
Thank you very much, Robin. I wish I were as glittering as you've painted me. Thank you all for having me here. Thank you to Poppy, my glorious goddaughter, for suggesting it in the first place. Now, there's a little bit of a difference in the title from the one that was tweeted out and decided on my behalf by the York Union. I apologise if you're expecting to hear about world policy. I'm afraid that's a bit of a big subject for me. So I'm going to talk about sex and drugs, if that's okay. AIDS is a mass murderer. Who agrees with that? I disagree with it, kind of. And the reason I disagree with it is because of this. Now, this is UK data. This is just for gay men, who account for more than half of the HIV epidemic in this country. And you can see that in the space of just 3 years, AIDS, which was killing over 1,000 people a year, dropped to just 100 and some. Now, what happened here?
Antiretrovirals.
Antiretrovirals. It was not campaigns with Hitler and Saddam Hussein and mass murders on them that caused that drop. It was antiretrovirals. So, in the UK, certainly, AIDS is no longer a mass murderer. Now, of course, you know, there's the whole of the rest of the world. This is a guy called Joseph in Haiti, which is one of the poorer countries, the poorest country in the Western Hemisphere. And this is what AIDS looks like. And, you know, when you're looking like this, obviously you're not having that much sex, you're not getting out much, but you are a reminder to the community of why you want to protect yourself. And you're probably a more effective reminder to the community than a sexy ad with Hitler at the end of it, right? Now, this is a reminder to the community of why you might want to be having sex in the first place. And this is also in Haiti, and also a guy called Joseph. In fact, it's the same Joseph after 6 months on antiretrovirals. So treatment, which became widely available in this country in 95, 96, and widely available worldwide from about 2004, has had a really dramatic effect on AIDS. But both of these men, the same man, have HIV. So we used to do AIDS prevention like this. This was a very famous campaign in Australia, the Grim Reaper campaign. And basically, anti-AIDS campaigns, HIV prevention campaigns, which were also AIDS prevention campaigns, used to look like this. It was all tombstones and Grim Reapers and death and don't fuck without a condom, because if you do, this is what's going to happen to you, right? Nowadays, this is AIDS prevention. AIDS prevention is take one pill a day. How many people in this room take one pill a day so that they can have as much sex as they want without any really negative consequences, like pregnancy? I'm not the only one. Thank you. Okay. And blokes, if you could, you would too. I don't doubt it. So, the difference between AIDS prevention in a treatment age and AIDS prevention in a pre-treatment age is very great. So we're very good at AIDS prevention now. We're rolling out antiretrovirals all around the world, and AIDS deaths are dropping very dramatically. HIV, however, is a slightly different story. Now, I'm sure that you all know this, but just viremia 101, HIV is not very transmissible. It's actually quite a fragile virus. It's not very easy to transmit. You think, oh, if it's not easy to transmit, how did we ever get to a total so far of 70 million infections around the world? Well, it's because of viremia. So this is the likelihood that you'll transmit HIV is largely driven by your viral load, the amount of free virus that is in your blood and your body fluids at any given time. And that's extremely dependent on where you are in the course of your infection. So what happens is you get infected, your body begins to stamp out virus, copies of the virus, you've got them all circulating in your blood and your body fluids, then you start to make antibodies. And the antibodies are at first very successful in suppressing HIV. So then the HIV basically, to oversimplify, hides out in your healthy cells. And you can go on for many years, an average of 9 or 10 years, without really being very infectious. Now, the virus will spike up again in your body fluids, particularly in your genital fluids, if you have another STI infection, if you get a clap or, kind of more chlamydia, gonorrhea, syphilis. HSV2 is a big one, which most of us have. But basically, you're going to go along without anything much happening until you start to get symptomatic AIDS. And that's over the course of time, the virus is breaking down your body's defense systems, and it then begins to win this battle. Now, so how we can prevent HIV being transmitted in viral terms is to try and keep the viral load low. Now, this is one of the things that antiretroviral treatment does. So, for those of you who read or are at all interested in HIV, read anything that's out there, there's a big mantra at the moment, which is, treatment is prevention. And the reason that people say treatment is prevention is because treatment brings down your viral load. And if you can control your viral load, you can keep it low, then you're going to wipe out all of this, and actually the likelihood of being infectious enough to pass on HIV is very low. Is everyone with me so far? Is there anything I've said that doesn't make sense? Okay. So, HIV brings down your viral load. So does that make you more infectious or less infectious? Just testing. Less infectious. Okay. So here's what we've got. We've got, in a pre-treatment age, about 10 years since infection, and now HIV, now you're going to go on to treatment and it's going to bring down your viral load, right? So you're going to get less infectious. But wait a minute, what happens if you don't have treatment? What happens if you have HIV, you're getting to symptomatic AIDS, and you don't get treated? You're done. What's your viral load when you're dead? 0. Your viral load when you are dead is 0. So now, if you're on treatment for many, many years, is your viral load higher or lower than if you're not on treatment? It's actually higher. because it's more than 0. And it's particularly more than 0 in all of these times when you are looking like the second Joseph, not like the first Joseph, and you're hot and healthy and still going out and still getting laid and potentially exposing other people to virus, and particularly potentially getting other STI infections that cause these peaks. If you go on a 4-day drug-fueled binge and forget to take your antiretrovirals because you're taking other drugs, then you also are at the risk of treatment interruption, antiretroviral failure, which also creates these spikes. So now, treatment is prevention. Not so black and white, is it? And if we look at the evidence from countries like this one, where we've had almost perfect access to antiretrovirals for everyone who's diagnosed for 15 years now, here's what we see. We've seen it before. So, hallelujah, in 3 years, AIDS has almost disappeared. What's happened to HIV? New infections. New infections. This is just among gay men in the UK. But you can see that shortly after, so we had, unfortunately we don't have bi-year data that go, for this population, that go back much further, but essentially new infections did drop because of prevention in the community, and then quite soon after universal treatment became available, newly diagnosed infections began to climb, and they have kept climbing ever since. So that whole treatment as prevention thing, for me, is a very big question mark. Now, of course, what happens when, because HIV is a lifelong infection, what happens when the gap between this line, which goes down, death is going down, which means more people are living longer with HIV, and new infections are going up, which means there are more absolute people with new infections, what does that mean for the absolute number of people who are living with HIV? It's growing. So that's on a different scale, because I have to show you the absolute number. This is now those same, the new diagnoses, significantly higher than the deaths, and by definition, because the data are cumulative, this is what you've got in terms of the absolute number of gay men living with HIV in the United Kingdom right now. Now, it looks the same for other populations on a much smaller scale. So these UK data, we've had perfect treatment for a long time. But in so these are the most recent data by UNAIDS. They do figures every 2 years by region. And you can see the important thing here is to look at the difference between new infections, incidents, and deaths. And in every region of the world now, new infections are outstripping deaths. And that's going to increase that difference. Why is it going to increase? Because we're doing so well with treatment. So this is the great success story of AIDS prevention. Not of HIV prevention, of AIDS prevention. The great success story is the number of, these are raw numbers of people on antiretroviral treatment. Now I have to tell you a little story. When these started in 2003, at virtually 0 for antiretroviral treatment in poor countries. I was working at the WHO in 2000, and we were asked, I was in the EPI team, and we were asked to make estimates of the cost of really attacking this, this epidemic globally. What would it cost? And we started doing our costings, and if you needed to provide condoms and lube and sexual health services to all gay men everywhere, and then you were going to do it for sex workers in all countries, right? Whatever, we did it by region, depending on the transmission paths in each country. And then we said, and if we were going to put everyone in sub-Saharan Africa on treatment. And the director of UNAIDS came back to us and said, take the treatment data out. And we were like, you've asked us to address how much it's going to cost to really do something about this epidemic. We were like, yeah, but we can't even talk about treatment in Africa because it will scare all the donors off. It's just too big a number. It's never going to happen anyway, so let's just not even talk about it. That was in 2000. And then what happened, amazingly, this is so off-piece, but I've just got to tell you because it's quite interesting. What happened was that the Christian right in the United States of America discovered innocent women and children in Africa. And HIV, which had always been those faggots and those junkies and those whores, you know, was suddenly a disease of innocent women and children in Africa. And we could redeem them by giving them very expensive pharmaceuticals made by American companies in my state, Senator Jesse Helms. And so suddenly there was this huge amount of support from the Bush administration for a campaign, a program that came to be known as PEPFAR. And suddenly the Americans had pledged $6 billion over several years for treatment in Africa. And that was what was basically what kick-started this. So, you know, thank you, Jesse Helms. I never thought I'd find myself saying that, but it did turn out to be a very good thing. So now we have over 9 million people in developing countries on antiretrovirals. Only 12 years after I was told, take it off the spreadsheet, it's never going to happen. There's no point in even estimating it. So that's absolutely dramatic. And they are, you can't see it very well on this slide, but they're predicting and hoping for 15 million by next year, and they're pretty much on course to get there. So it's really astonishing. It's also partly because the drug companies have actually done some pretty good work in developing ARVs that are easier to administer. Now, exactly the same thing globally. It looks like it's the same slide as before, but it's on a very different scale. But what it means is, because the red line is above the blue line, consistently, the green line gets higher. So we have consistently, as we're taking care of the AIDS problem, we're growing the HIV problem. So, who are all these people? I'm just going to digress for a minute because I was asked a question earlier. I took the slides out and put them back in slightly about Africa and the difference between Africa and the rest of the world. So essentially, we have, these are slightly old data, sadly they haven't gone down very much, but we're talking about the adult population in some countries, up to 1 in 3 adults being infected with HIV. So just quickly, put up your hand, and every third person in this room, I mean, you can see what that gives. It's, of all adults, 1 in 3 is infected. In several countries, in southern, particularly Africa, and to a lesser extent in East Africa, we've got these vast amounts of infection. In the rest of the world, there's basically nothing going on. We've got no real evidence. Except in very well-defined groups. So, New York City, almost 1 in 3 gay guys, sex workers in Mexico, a quarter, transgenders in Jakarta. This is a study I did some years ago now, over a third. You know, drug injectors up to 1 in 2 in some cities. So we've got epidemics that are as big as the African epidemic, but only in subpopulations, and generally in subpopulations that we don't give a shit about. Or at least that politicians don't give a shit about, right? So we've got these very big disparities in these two epidemics. So most of what you read in the papers and most of what people think about when they think about HIV AIDS, which I would argue are 2 different things, is this. But actually, there's also, you know, these other people amount to 10 million people. Now, on this slide, yeah, everyone, all but 1 people on there have a penis. All but 1 of them I know. I've been in love with several of them. I've slept with a few of them. I was even married to 1 of them. Probably don't tell. And every single one of those people is at one of those high-risk groups, either a gay guy, a male sex worker, a transgender sex worker, a female sex worker, or a current or past injection drug users. One's also my yoga teacher. Okay. So this is the face of the epidemic everywhere except sub-Saharan Africa. Now, that gives us a truth that has been very uncomfortable for people to talk about. But, you know, oh, HIV, it's a problem of development, it's a problem of poverty. No, it's a virus. not a development problem, it's not a problem of poverty, it's not a problem of globalization or anything else, it's a virus. And because it's a virus, it can only be transmitted in certain ways. And those ways require a large number of people to be exchanging body fluids during those quite short periods of time when you've got that peak viremia, right? So it doesn't matter. You can have 40 sex partners over 6 years. As long as they're 3 months apart, it doesn't really matter very much. Because even if one of them infects you, you're probably not going to be viremic by the time you have sex with the next one and have a chance of passing it on to them. So, don't say I told you. Yes?
Can you pass it on if it's not in the slide?
Much, much more difficult. I mean, technically possible, particularly if you're having anal sex, or if you've got, if you have abrasions or lesions and your mucosa aren't intact, it's much, much more possible. It's one of the reasons that gay men are so much more infected, because you're much more likely to have lesions in anal sex than in vaginal sex. But it's, and obviously injection, yes, even with low viremia, if you're sharing injecting equipment, you can pass it on, and that's another reason why rates in injectors are so high. But in regular, vanilla, heterosexual sex, almost no. You know, but we're not allowed to talk about those things. I'll come to that in a minute. We're not allowed to talk about those because I've got to tell you, never fuck without a condom, ever, ever, ever. Because, you know, but it's bollocks. Sorry, just saying. So what that brings us to is that globally, the people who are most likely to be having multiple partners in rather short, or multiple exchanges of body fluids in rather short windows are gay guys, men who are in jail, regardless of their sexuality, people who inject drugs, people who sell and buy sex of all three genders, and East and Southern Africans. Now this makes people crazy, of course, because it's racist, or it's, you know, homophobic, or it's, but actually it's just what the data say. So this is an interesting study that was done in London. Sorry, I haven't put a year up there. It's the data is from 2006 to 2008. They're from the same clubs. We're not even talking different clubs. Same clubs, asking hetero guys and women and gay guys about their recent sexual partnerships. And, you know, actually, women and men, heteros are generally kind of agreeing on the levels. Men don't get laid that much, gay men don't get laid that much more in a 3-month period, but actually they're averaging much more frequent turnover and higher partnership numbers in that time. Same thing with East and Southern Africa versus the rest of the world. These were studies that were done in 1989 and 1990, right back at the beginning of the epidemic. They were done by the WHO. Before UNAIDS even existed, it was called the GPA, the Global Program on AIDS. And when these data came out, everyone took it. It was the three monkeys approach to public health. We can't actually publish these data because people will think it's racist. Which kind of suggests, well, why? Because Africans report more sexual partners, which suggests that more sex is somehow a bad thing, right? Because racism is a bad thing. Good for you. Just saying. Okay, but it's actually not about the number of partners. As I said, it's about networking. And what happens in why East and Southern Africa, because they are parts of the world that have quite high levels of female autonomy and quite high levels of culturally embedded polygamy. So the traditions of polygamy allow for men to have multiple female partners, right? Men are allowed to have lots of wives. In many of the traditions of East and Southern Africa, female sexuality was not controlled in the way that it is in other polygamous societies, notably Arabic societies and other Muslim societies. So where you had women who are allowed to get around as long as they do what they have to do for their husbands, and a culture that allows for that networking, what you get is this. So these are data from Malawi
And this is for 7 villages, and 65%, so nearly 2/3 of adults in those 7 villages were linked into a single sexual network. So that means that, you know, you may only have 3 or 4 partners in your whole lifetime, which is a great deal fewer than many people in this room, I'm sure, you know, and yet, because you have those 3 or 4 partners more or less simultaneously, you're more likely to create a network that spreads this virus. Does that make sense to everyone? So it's not about numbers of partners, it's about timing, basically. Okay, these are UK data. So why are we know all this, and we've known all this since the early 80s, essentially, sorry, the early 90s. So what are we doing wrong? I think one of the things we're doing wrong is that most HIV prevention campaigns are designed by people like me, who are just like public health nerds, okay? So we have something we call the health belief model. This is one of the models that underpins a lot of public health work. So what we have to do is we find the problem, and then we find out what people, we give people the information about that problem, and then we give them the tools to change their behavior, and etc. So this is a real example that I stole from a conference that I went to in Texas not that long ago. So problem statement, STD rates are high among young Hispanic gay guys, right? They don't use condoms, and they have multiple partners, right? Why? Because they don't know how to use condoms properly, and even if they know how to use them, they don't know how to negotiate them. Not like that, okay. So what we're going to do is we're going to do condom skills demonstration, and role play, and self-assertion, and now, excuse me, but would you usually hold on, it gets better, sorry, I couldn't put it all on one slide. So then we have this, and then they know, we've taught them, so they know how to use condoms, right? And bingo! They use condoms. Does anyone have a problem with that? And apparently it's true because, so when I gave a talk, I can't remember, I think it was my TED talk, and some guy wrote to me, and I said, because I said, look, carrying condoms doesn't protect you from HIV, right? So I get this email randomly, I hope you don't know this guy, I should black out his name. But he said, think about it. If you were getting hot and heavy, I did not make this up, I promise. If you were getting hot and heavy with some guy, neither of you had a condom handy, would you say, let's go for it? I doubt it. Either you'd go to the 7-Eleven and get some condoms, or you'd say, well, maybe another night. Am I the only one in this room who feels No, sorry, no, let's 7-Eleven's closed. Oh, damn. And he's not even a public health nerd, he's just some random dude who needs to go figure. So we're going to try this again. Drug injectors, okay? Needle sharing, the thing is that public health nerds think that everyone thinks like a public health nerd, right? Instead of thinking that they think like a human being. Let alone like a human being who likes to get high on illegal substances, or a human being who likes to get laid as often as he or she can, or whatever. Okay. Needle sharing spreads infection, that's my problem, right? Your problem is that needle sharing is actually pretty gross. If you're a junkie, it's gross. In the same way as, you know, sharing your boyfriend's or your girlfriend's toothbrush is kind of gross. Even, you know, you're sticking your things in one another's mouths the whole time, doing hideous things with body parts and whatever, but actually sticking their toothbrush in your mouth is still kind of gross, right? Well, it's the same thing with needles. It's really no fun. So my problem is infection. Their problem is it's just gross. So I want to stop them sharing, and they want to stop sharing. So if I give them clean needles, they'll use clean needles. Bingo, right? So it's exactly the same logic, isn't it? Except, okay, public health nerd, unprotected spread, we're doing the other one again, right? Unprotected sex spread infection. Gay guy. What's your problem? Is it unprotected sex spreads infection? Yes? Do you know, God, most people I talk to don't use condoms because actually sex without a condom is more fun than sex with a condom. So they say. Right? So we've got completely different problem statements. Most people, when they've, you know, when they've got an erection, are not thinking, oh gosh, I must go to the 7-Eleven because there's a chance of infection. True
because I need to increase condom use. But their solution is, you know, condoms suck, so I'm not going to use condoms. So what action do we take? Well, I give them training in condom use, right? And bingo. It's this failure to actually, for the public health establishment, to actually think like real human beings. Now, I'm very sad because I put on a sign to bring my my favoured prop, but I failed to bring it. But I've got a picture of it here. Who knows what this is? Right. Well, but according to the official guidelines of the UK Sexual Health Association, it actually should be used by nurses to measure up people's penises to fit them for condoms. I am not making this up. I am really not making this up. So they say that nurses in sexual health clinics should help people to be more comfortable with condoms by sizing them properly by using a pasta measurer. I promise you, I went out and bought a pasta measurer after that for this very purpose. Okay, so the sexual health establishment says to you, listen, you've got to use a condom every time you have vaginal, oral, or anal sex to minimize the risk of transmission, blah, blah. And that's what I'm supposed to tell you, right? I'm not supposed to tell you, honestly, this bollocks. That's what sexual health professionals are allowed to tell people. We've got to tell you zero risk. But the point is that most people aren't morons. They're really not. And so there are all kinds of other strategies that people develop to try and minimize their risk, harm reduction on different scales. So these are data, they're quite old data now, and nothing has changed since then, I'm sad to say. Which is, so they're calling it seroadaptation, which is a way of minimizing your risk if you know that you're in a serodiscordant or might be in a serodiscordant relationship. Serodiscordant means one of you's positive and one of you's negative, HIV. So you've got all these different things that people are choosing to do to reduce their risk. And actually, quite a lot of these things work quite well. And I don't have time to run through them all, but actually quite a lot of them work quite well. This is the most effective, if you can stick to it, I have to say. People say, oh, abstinence doesn't work, but abstinence does work if used correctly and consistently, just like condoms. Unfortunately, no. Now, the most dangerous of these, and I really want to point this out, well, most strategies pretty dangerous, but serosorting. So serosorting means having sex with someone who's of the same HIV status as yourself. So if you're positive, you only have sex with other positive. If you're negative, you only have sex with other negatives, right? And you go on Gaydar or Grindr or any of these things, and people will advertise their status sometimes, and sometimes it will be honest, and sometimes not. I just want to bring your attention to these data, which is from the analysis was only done 2 years ago. The data are rather older, but they're from studies in the United States in 16 cities compiled by the New York Department of Health. And what they did was they went to venues, gay venues, and street fairs and stuff, and they took oral swabs from people, because you can do an HIV test on a saliva sample, and they asked people, are you positive or negative? And they then anonymized but linked the data, and then they tested. And what they found was, these are people who say they're negative. Of the people who say they're negative, among black guys, more than a quarter are actually positive. But even among, you're talking between 1 in 10 and 1 in 4 are actually positive. And among guys who say they don't know, almost half in some groups are actually positive. So if you say, well, I'm negative, and I'm going to have sex only with someone else who's negative, depending what community you're in, you've got a pretty high chance of getting it wrong. Now, some of these people will think they're negative because they had a recent negative test. And I looked at the data, and about a third of those who said they were negative had had a negative test, said they had had a negative test within the last 3 months. What does that mean? So 3 months ago they were negative, now they're positive. They're really infectious. If that's true, if those dates are true, it's quite likely that they're somewhere in that
high peak. Now, that's partly because of the way human behaviour works. So all of the HIV modelling we do, most of the HIV modelling we do until very recently, has assumed constant levels of sexual behaviour across Europe. So you have an average of 1.8 new partners a year, or whatever it is. And our models run that 1.8 new partners a year through the whole course of your sexual lifetime. But in my experience, at least, it doesn't go like that, right? It goes, you're in a relationship, you break up, you salt for 3 weeks, then you go through your slutty phase, right? You hit the clubs, you get around a bit, you see what you can get away with, and then maybe you get fed up with it, or you find some bloke that you like, or, and then you settle down for another couple of years, and then it all happens again. So the times at which people are having sex with new partners tend to be in phases where people are having sex with quite a few new partners all at once. So that's something to be concerned about. Now, I'm getting close to the end, and I know, Robin, that I'm over time, but I am aware of that. So here's data from a study from the Kaiser Family Foundation, which is absolutely a very, very good foundation, and they've been tracking attitudes to AIDS. And they ask these questions about stigma. And, it's people's own fault if they get AIDS. These things are clearly stigmatizing, right? I sometimes think AIDS is a punishment for decline in moral standards. I only think that on Sunday mornings when I get back from the club. No, it's people's own fault if they get AIDS. Obviously that's stigmatizing, right? Well, hold on a second. It's 2014. If you're a gay guy in the United Kingdom and you get newly infected with HIV, whose fault is that? Just asking. The point is that we have, in the effort to reduce stigma associated with HIV infection, we've kind of taken personal responsibility out of the equation. We are living in a society where knowledge is more or less universal, at least in the subpopulations that are most at risk, where availability and affordability of prevention options is more or less universal, and we're still getting more new infections now than ever before. Whose fault is that? But this puts us in a very difficult position because, you're all looking horrified. Oh my God, she says it's someone's fault if they get HIV. But truthfully, we're stuck in this bind of not wanting to stigmatize and not wanting to say there's anything bad about having HIV, because if there's anything bad about it, then it stigmatizes people with HIV. So everyone who's HIV positive is now happy and joyful because they've all got meds and it's all fine, right? Here's an ad.
When you get HIV, it's never just HIV. You're at a higher risk to get dozens of diseases even if you take medications, like osteoporosis, a disease that dissolves your bones, and dementia, a condition that causes permanent memory loss. And you're over 28 times more likely to get anal cancer. It's never just HIV. Stay HIV free. Always use a condom.
So that's a prevention ad that was made by the New York City Department of Public Health 3 years ago. What do you think they were trying to do with that ad? Yeah, we can't scare people with, you're going to die, anymore, because it's not true. It's really hard to scare people with, use a condom every time you have sex, no matter how high you are, no matter how drunk you are, because you might have to take a pill every day. It's hard to scare people with that. So we're trying to scare people with other facts about the disease, because it is still shit being HIV positive, frankly, even though you have to take a pill every day, you're not going to die, it's going to be fine. But there are other things which are rather difficult and uncomfortable about it, not least the whole question of disclosure every time. I have pubic hair, imagine that. I have to I can't take my knickers off before having the conversation with some new partner because they might be shocked because, I'm so old-fashioned. Imagine having to tell people you've got HIV. You have to pick every single, it's a nightmare. There are very bad things about it. But we're not allowed to say that anything's bad about it because that's stigmatizing. So this ad, which was trying to say, HIV, actually there was another one in Australia, which used the slogan, HIV's no picnic. Those ads got taken off the air. Why? Because the pause community, and there is such a thing as a pause community, objected that they were stigmatizing to people with HIV. So here's my question to you guys, and I'm going to finish here, but here's my question to you guys. The young generation, you are the post-AIDS generation. First of all, is there anything, maybe there's nothing bad about being HIV positive, except for me, from the public health nerd point of view, there is something bad. Because you know what, and it's going to be bad for you too, because you are paying taxes to pay now for 131,000 people on meds in this country, and that pool is getting bigger and bigger, and the meds are not getting much cheaper. So, number one, we've got a problem of expenditure, and number two, we've got a problem of the potential for resistant viruses developing, and those are, thank God, at the moment developing much more slowly than we expected or feared. But if we get if we get viruses that are resistant to drugs, then we're right back to 1986, and then we can use the Grim Reaper, we can just pull out the Grim Reaper ads again, and it'll all be fine. So we're in this bind, and I really am finishing now, I really am. But I have a question for you guys. How do we do prevention for something when we're not allowed to say it's bad? HIV is just fine, take your drugs, we don't want to stigmatize anyone, but don't get it. It's not working really well for now, so it's up to your generation to find another solution. Thank you.